This is the second part of our discussion on coronary artery disease. From there, we will lead into the topic of angina as well. Now, potential side effects of using these medications to lower lipid levels in the bloodstream are listed here. There, of course, are the GI disturbances, which include abdominal discomfort, diarrhea or constipation, and nausea. Any of those can show up as a side effect of using these medications. However, again, they are minor complaints. They're nothing that really is of great concern in terms of the patient's well-being. What we do and monitor and what we are concerned about are any changes to the liver as a result of these medications. Hyperlipidemia therapy can cause damage to the liver. So we look to see if there is any elevation in liver enzymes, specifically the AST and ALT. We can also, because of the liver damage, see a prolonged prothrombin time, the PT, or the length of time it takes to form clots, can be altered in the liver when there's damage there. So this is what's important. We certainly don't want to continue using medications that are going to damage a patient's liver. So put that as a star. That's much more significant. If it does become a side effect, then we would have to address it, either by discontinuing the medication or by ruling out any dysfunction to the liver before we continue using it. Now, all of these hyperlipidemic agents take several weeks to take effect. To really show the effectiveness that we're looking for, that increase in HDL, that decrease in LDL and total cholesterol, those things aren't going to show up immediately. Okay, they take several weeks to get the maximum benefit from them. Just as this cholesterol, this atherosclerosis did not develop overnight, neither is the process of lowering all of those serum lipids. Now, the final classification of anti-hyperlipidemics that we're going to discuss are called the statins. And they're quite easy, at least in terms of how they're spelled, to recognize them. They all end in the suffix statin. So we have the generic name on the left and the brand name on the right. Probably a lot of you have heard of Lipitor or Crestor. Lipitor is called atorvastatin. Crestor is called rosuvastatin. They are very commonly used statins to lower an individual's cholesterol levels. Again, to improve the HDL and to decrease the LDL. Then we also have lovastatin, pravastatin, and simvastatin. Okay. And you can see here the effect that it has on the atherosclerotic plaque that is in the coronary vessels. Okay, so as time goes on, as week after week, and month after month, we see the elimination of that plaque. And that's restoring perfusion. Now let's talk about the mechanism of action for our statins. Remember that the other name for statin is HMG-CoA reductase inhibitors. And that name in and of itself explains how this medication works. Okay, because in the liver, remember that the liver makes or synthesizes cholesterol. So these statins have their effect in the liver. And one of the enzymes that is needed to produce cholesterol in the liver is called HMG-CoA reductase. Remember, enzymes end in ASE. And in this picture, we see it in green. That enzyme is needed to convert HMG-CoA to malevolate. And it does that, and eventually, after the sequence of steps, we end up with cholesterol in the bloodstream. But what statins do is that they block that enzymatic reaction. That's how the medication works. So statins will inhibit, you could put a big X right there between HMG-CoA and mevalonate. Put a big X there because that's where this medication works, in the liver, to prevent the synthesis or production of cholesterol. Side effects are just like all the others. Possible GI upset, constipation, diarrhea, flatulence, whatever, and liver changes. Potentially, we could have damage to the liver, so we will monitor liver enzymes in these people. All of the statins have different potencies, like different strengths or their ability to impact the level of circulating lipids and cholesterol. So atorvastatin is just one example of a statin that is very effective. Okay, so rhabdomyolysis, or rhabdo, causes the destruction of skeletal muscle fibers, as we see in this picture. And when it is destroyed, it releases potassium, phosphorus, myoglobin, creatinine kinase, and urate. Also, the destruction of the skeletal muscles causes pain and or muscle weakness in our patients. So they may complain of muscle aches or some kind of skeletal muscle pain. And so we have to pay attention to that complaint when we understand that they are taking a statin, and a statin can lead to the destruction of skeletal muscle cells. So let's get back down here to these things that are released when it's destroyed. Myoglobin. Okay, myoglobin is a large molecule. It's made up of subunits. So whenever you see that word globin, you're going to think of a large molecule, very big and bulky, comprised of subunits. Now those big molecules get filtered through the kidneys, but they don't get very far. Instead, they clog up the little nephrons and tubules, and we end up with damage to the kidneys. So that renal tubular obstruction is caused by the large myoglobin molecule. And that's how it can lead to acute renal failure. So when a patient who's on a statin comes into the clinic and we're following up to see if they have any side effects, and they say they have aches and pains, a kind of muscle aches and pains, or perhaps even weakness of the muscle, then we would want to order a creatinine kinase level. It's a serum lab analysis. We just have to draw a specimen, a tube of blood, send it to the lab, and ask for a creatinine kinase level. I say that, I want you to realize that the CK on this slide stands for creatinine kinase. Okay, so we will monitor the creatinine kinase on that patient if they complain of any weakness or pain once they have been started on a statin. We don't have to stop it immediately. Well, I take that back. We would probably stop it immediately. At least we would probably hold it until we get the creatinine kinase levels back. Because if the creatinine kinase levels come back and they're not elevated, well, then their muscle aches and pains are not due to the statin at all. Okay? But if they are elevated, then certainly we have to stop, discontinue that medication. And like we said earlier, it's not a problem necessarily. If they cannot tolerate a statin, it does not mean that we don't have other options available for lowering their hyperlipidemic condition. Okay? All right, moving right along. As you can imagine, when you have atherosclerotic plaque building up inside your coronary arteries, there's going to be a problem with perfusion, with blood flow through that area. And that means that the cardiac muscle distal to that tissue is not getting perfused well. And the tissue becomes ischemic, and that leads to angina. There are different types of angina. Okay, so angina is chest pain that results from reduced coronary blood flow or ischemia. 3 types of angina have been identified. They're on the slide. Stable angina, Prince-Meadows angina, also called variant angina, and unstable angina. I like to highlight that or put it in bold because unstable angina is unrelated to activity. Okay, in other words, the patient doesn't have to be doing anything and he can develop chest pain. Typically, though, angina is precipitated by an identifiable event, and that is our stable angina at the top of the list. Sometimes this is also called classic angina, so you may want to write in parentheses classic next to stable angina. And this is how this one works. It is related to activity. First there's activity, then there's pain, then the patient rests, and then there's relief of pain. Okay? So the sequence is activity, pain, rest, relief. Okay, that's your classic or stable angina, and it is the most common type of angina. So it occurs when the work of the heart is increased by physical exertion. Okay, it can also be exposure to extreme temperatures or stress. But stable angina is relieved by rest and nitrates, like nitroglycerin. Okay, so we'll talk about that in a little bit. But you know it's stable angina when you give the nitroglycerin and it goes away. Okay, then that is a sure indication that it is angina. Now, Prince-Meadows is an atypical type of angina, and it occurs unrelated to activity as well. It's very unpredictable, and it often occurs at night. In other words, that patient will wake up in the middle of a dead sleep because his coronary artery is spasming. Okay, it doesn't have anything to do with atherosclerosis. It's simply a spasm of the coronary artery, and it's very painful from what I understand. But it does go away. Pretty much, it resolves on its own. All right, just one other thing I'll mention here about that unstable angina that's unrelated to activity. This is the one clients with unstable angina are at risk for myocardial infarction. In other words, they are at risk of having a heart attack. Now, I also want to mention what I have in the picture here. We see somebody with symptoms. And when you call the doctor and tell them that your patient's experiencing angina, he's going to ask you, and you give him the vital signs, he's going to ask you, is the patient symptomatic? So We want to make sure we've done this assessment on the patient before you call the physician. By symptomatic, we mean are they experiencing pressure in the chest? Is there pain radiating? These are things you can ask the patient before you go and call the doctor. Is the patient lightheaded? Are they sweating? Are they diaphoretic? Are they nauseous? Okay, any of those symptoms would put the patient in that category of being symptomatic. Okay. The symptoms of angina vary among individuals. The discomfort ranges from a tightness in the chest to severe pain. Okay, and it may occur anywhere from the belly button up to the top of the jaw and down both arms. Okay, the discomfort often starts in the chest and spreads to the arms and even up to the neck and jaw. Sometimes it spreads around to the back. The pain or discomfort is usually continuous, meaning it's not sporadic, it doesn't come and go. As we said before, it usually happens when people are walking or doing something that takes some effort. It lasts longer than a few seconds and eases off when exertion stops. It may even occur when the patient becomes very stressed, and then it eases off once they become more relaxed. But the pain does not usually vary with breathing or with changing your posture, which can occur with other problems associated with the lungs and the chest wall. Okay. Pains from the food passage are often precipitated after eating and when one lies down flat at night. However, angina may also be precipitated by a large meal. Angina usually gets worse if one continues to exercise. But chest pain that allows a person to keep running around and doing physical activity is unlikely to be angina. Okay? Angina, relief from angina is usually rest or stopping the activity. Now, the patient may describe the pain as a tight, squeezing, heavy, sharp, or constricting substernal pain that radiates to the jaw, the epigastric area, or the back. Additional symptoms or manifestations include dyspnea, pallor, tachycardia, and a great anxiety or fear. Now, we must mention women here because women frequently present with atypical symptoms, such as indigestion, nausea, vomiting, and upper back pain. Angina, also called angina pectoris, is chest pain as a result of myocardial ischemia. Okay? It typically lasts 3 to 5 minutes and subsides. So it commonly subsides when the precipitating factor, whatever the stressor is removed. It should not persist more than 20 minutes after rest or 20 minutes after taking sublingual nitroglycerin or any nitroglycerin. Okay? Angina is the direct result of myocardial ischemia. This discomfort or pain occurs because the oxygen demand is greater than what the coronary arteries can supply to the myocardial tissue. So the demand is greater than the supply of oxygen to the tissues. The difference between angina and heart attack pain is this. Anginal pain is of short duration and is usually relieved by rest. So I want you to understand that pain, chest pain caused by a heart attack is not relieved by rest. It is not even relieved necessarily by taking a sublingual nitroglycerin. Okay? It persists for a long time. I mean, comparatively a long time, more than 20 minutes, right? After they stop exerting themselves. Okay, so let's look at the precipitating factors, those things that can bring angina on. Physical exertion, strong emotions, eating a large meal, temperature extremes, cigarette smoking, sexual activity, and stimulants. Okay, so here we're going to talk about stable or classic angina. It occurs intermittently over a long period of time. In other words, every time this individual goes out and mows the lawn, he experiences chest discomfort or pain. He goes in the house and lays on the couch and the pain goes away. So it comes and goes over months, over a long period of time, maybe even years. So this is something that comes and goes, and it's directly related to exertion. But we see the same pattern of onset, the same length of duration, and the same intensity during this time. So in other words, it happens every time he mows the lawn. It lasts the same length of time until he goes in and rests, and it always feels the same. It's not getting worse, it's just always the same intensity. Generally, the intensity is described as anywhere, really there's lots of variety, from mild to severe, but it does stop once they rest. Now, unstable angina, we said, was unrelated to rest. In this type of angina, which remember can lead to heart attacks, is progressive. It's even described as crescendo or pre-infarct. It's very different from our classic angina because it is unpredictable. Over time, it gets worse and worse, and it gets more and more frequent. So it is not associated with exertion. It can occur when the patient is asleep or at rest, and so we have a picture of somebody laying on the couch. So they can just be asleep and all of a sudden they wake up with chest pain. And it does get more frequent and more severe as the months go on. What we're seeing, what's occurring with unstable angina, is that there's more and more stenosis, so that the lumen of the vessel is not as opened as before. The intensity of the angina increases over a period of usually 3 months, and within about 18 months of having unstable angina, the person develops a heart attack or a myocardial infarction as that atherosclerotic plaque increases in size, and then we have the platelets and the blood clotting and everything going on until eventually they have a complete heart attack. And remember, heart attack is an occlusion of a coronary artery. While there may also be a spasm component to unstable angina. So that in addition to the blockage that's going on, we can also have the coronary artery spasming, making it even worse. Often treated with calcium channel blockers. So I want you to remember this in terms of calcium channel blockers. They cause vasodilation. Okay? So if calcium channel blockers cause vasodilation, then that will help to reperfuse that tissue distal to the blockage. Okay? Also, a treatment of choice is aspirin. ASA stands for aspirin, or any other anticoagulant, because we want to make sure, at least with aspirin, that we don't have the platelets sticking together. That's what aspirin does. It prevents platelet aggregation. And so that may benefit this person who is having a clot and occlusion of the coronary artery. And that third atypical type of angina is called Prince-Metal's angina. It usually occurs at rest, and it is associated with a spasming of the major coronary artery. As we said earlier, it may not be associated with coronary artery disease at all. It may occur while they're at sleep, rapid eye movement, in a very deep sleep. It can be resolved on its own, or it could be relieved by exercise. So if the individual gets up out of bed and begins walking around the home, then they may cause it to spontaneously disappear. And according to the patients, it's intensely painful. So when they wake up, they really believe they are having a heart attack. Nitroglycerin works by relaxing the blood vessels and increasing the supply of blood and oxygen to the heart while reducing its workload. Okay, so we'll review this again. Nitroglycerin, first of all, it dilates the peripheral veins. Okay, that means there's more of our blood volume is out there, as I say. More of our blood volume is out in the periphery. That means there is less volume returning to the right side of the heart. This decreases preload and immediately decreases the amount of work that the heart must do. And then that reduces the demand for oxygen. And we have the relief of ischemia and chest pain. Now, nitroglycerin also has another effect. It dilates the coronary arteries. Okay, this is wonderful because we want to dilate those arteries to improve the flow of blood and oxygen supply to the heart muscle, thereby getting rid of the chest pain or ischemia. In this picture, we can see a small bottle of nitroglycerin. These tablets are the sublingual type. They're kept in the dark glass vial, and once they're open, they're really only good for 6 to 9 months. And if there's any question about whether they're good or not, we can figure that out by having the patient put one under their tongue when they're in need. And if they feel that tingling sensation, then yes, it is still working. Okay, it is an inexpensive medication, but it does need to be replaced quite frequently. It needs to be kept airtight and in a light-resistant bottle, and frequently it's kept in the patient's refrigerator at home. If we have a patient who has angina, they are going to go home with some sublingual nitroglycerin. Okay, and we know it's fresh. As we said over and over, it's got that tingling sensation under the tongue. Now also these patients with angina can use this nitroglycerin prophylactically as well before any activities that they know to cause chest pain, including sexual intercourse. Okay, so in other words, if that man mowing the lawn knows that he gets chest pain every time he does that, he could take a sublingual nitro before he goes out and mows the lawn. Nitroglycerin comes in many forms, including the nitroglycerin patch. This is commonly used in the hospital for our cardiac patients. And when you go to the Pyxis system to retrieve the nitroglycerin patch, you're going to have a pad of paper in there, and you're going to peel off the top piece of paper. And then in another, next to it, you'll have a tube of ointment. So you're going to unscrew the ointment tube, and you're going to place the correct amount of paste on the paper. On the paper, it's going to measure, it's going to be like a measuring picture of 1 to 2 inches. And you're going to place in a line, you're going to squeeze it out in a line up to the dose that the physician has ordered. For example, you may receive an order that says 1 inch of nitro paste. So you just squeeze it out from the 0 to the 1 inch and return the tube to the Pyxis system. You only take your one piece of paper with your little line of nitro paste to your patient's room. Now you're going to apply it onto their skin. You want to avoid hairy areas. You can put it anywhere on the chest or arms, but truthfully, people put it in all sorts of places because you do want to rotate it. You don't want to keep putting it in the very same spot. Before you place the new nitro paste on the patient, the new dose, you're going to remove the old dose. Okay, you're going to look for the site where they call it a patch, but it's a piece of paper that's taped on the patient's body. So you're going to look for the old one and take it off and wipe that area with a paper towel. Usually I'll just take a paper towel from the patient's room to wipe off the excess paste that is still remaining from the last application. Once you've done that, you can place the new patch in a different area. Also be aware that, you will also, once you place the tape on the paper, you're going to initial it and write the time that you applied it, so we know when was the last dose was applied. I wanted you to also be aware that sometimes the physician is going to order a nitro-free period. And in that case, that means you need to go in and remove any patches that are there and wipe the area free of paste. And from that period of time, there should be no nitro paste on that individual. Okay, and well, that's good enough for that. Now, there are other forms of nitrates as well that can be used in the hospital, so I'm just going to touch on them briefly. One of them is nitrobid, isodyl sorbitrate. This is a long-acting transdermal ointment. Okay, so it goes through the skin and has an effect that way, and it's long-acting. Then we have Imdur, also called isosorbide. And it's important that really all nitrates should not be used with Viagra, okay, especially not while taking Imdur. The combination of Viagra and a nitrate can cause severe, life-threatening low blood pressure. Okay, so that's very important to take into consideration. What other medications that can lower blood pressure are being taken by the patient. Okay, we don't want to compound it so that it becomes dangerously low or life-threatening. And then we have a translingual spray, nitroglycerin spray. Personally, I haven't seen it, but there are people who have had the occasion of seeing this used because the nitroglycerin can be absorbed through the skin or under the tongue in this manner. Now, I just want to say that the onset of action of any transdermal nitroglycerin is not sufficiently rapid for this product to be useful in aborting an acute anginal episode. Okay, so if there is really an acute episode of angina, we don't want to choose a transdermal form of nitroglycerin, okay, such as putting it on the skin and a nitro patch. That's going to be too slow to give them the immediate relief that they're looking for. All right, so it's much better. You can do it sublingually or orally, but not through the skin. At this point, we want to talk about aspirin. Aspirin therapy is very important in coronary artery disease, or I should say angina, for those individuals having angina. Even a baby aspirin of 81 milligrams taken orally every day can be valuable. And it can be used as well in conjunction with other antiplatelet medications, such as Plavix. Okay? Plavix is an antiplatelet medication. Like aspirin, it prevents platelets from sticking together. Aspirin can also be given in a 300 milligram dosage every day. And it also can be used with older medications that are listed here: Persantine, which is a platelet inhibitor, Trentol, which decreases blood viscosity, and Pletol, which is an antiplatelet and vasodilator. So here are some older medications which, used in combination with aspirin, are effective in preventing platelets from aggregating. And this is the only example really I could ever give you that in which a medication, Trentol, decreases blood viscosity. So in that case, that is truly a blood thinner, but it is the only one that I'm really aware of. Now let's talk about intravenous nitrates. We have one that's used quite commonly in the hospital or in cardiovascular floors, and that is Tridol. Okay, so we're going to use intravenous nitrates when the angina is refractory to treatment. In other words, we've used sublingual nitroglycerin. It doesn't touch the angina. The patient continues to experience angina. That may be a case for using a continuous infusion of nitrates. And because it's intravenous, it has an immediate onset of action. And the nurse is responsible for titrating the dose. Frequently, they receive an order, titrate to relief. Relief of what? Relief of the pain. So we're going to keep going up on the dosage until the patient's angina goes away, or that we begin to see that it's coming down, because we are assessing their pain on a scale of 0 to 10. And if we start to see relief, it's coming down, then we have reached the dose where we want to keep it for a little bit. So we're always monitoring the patient's pain level when they're on IV nitrates. And not only their pain level, but the focus for nurses is the patient's blood pressure. We will obtain the blood pressure before administering Tridol. We will typically hold the administration of Tridol if the systolic blood pressure is less than 90. Okay, you're not going to start it if the systolic is less than 90, and you're going to be very concerned if the systolic drops below 90 when you are administering the Tridol. Okay, Tridol comes in a glass bottle, and because of that, it's special tubing as well that will vent the bottle so that it will drip. Otherwise, it'll be very hard to get that liquid to drip into the tubing. We also protect it from light, and so it will come with a covering, like a foil bag that fits over the bottle so that's not exposed to light. And again, how do we know if the medication is effective? because it's going to relieve the patient's chest pain. Okay? So we protect it from light to prevent the breakdown of the nitrates. Light breaks down nitrates and makes it ineffective. Okay, nursing care for patients with angina. But one thing I want to mention, I almost forgot to say it here before we go into the nursing care, is that acute coronary syndrome refers to unstable angina and heart attacks. So when you're reading your textbook and you come across the term acute coronary syndrome, abbreviated capital ACS, you have to realize that we're talking about unstable angina and myocardial infarctions. Also, chronic ischemia results from a partial obstruction of a coronary artery, or a spasm, or a thrombus, or blood clot. That's thrombus, blood clot. Okay, so there's a big difference between the two, and usually it proceeds in this fashion, from the chronic ischemia to the acute coronary syndrome. Okay, because chronic is partial obstruction caused by atherosclerotic plaque, or spasming of the coronary artery, or development of a blood clot. Okay, and then that evolves into the unstable angina, and perhaps within 18 months the patient develops a myocardial infarction. So that's kind of the big picture there. Now we need our patients to understand what causes chest pain. And it's different for every person, but remember, we have to go over with them any type of exertion and how the supply does not meet the demand for oxygen. We also can talk to the patients about positions of comfort if pain occurs. And certain positions require less workload on the heart. Certainly rest with their hands down by their side, not over their head, would be preferable because the heart doesn't have to work as hard. We have to discuss with them oxygen therapy. Supplemental oxygen is going to be important in their care to make sure that we get enough oxygen to the cardiac tissue. The use of the nitroglycerin and the relief of pain, of ischemia and angina through the use of sublingual nitroglycerin. We are going to monitor their vital signs very closely, and also the electrical conduction system of the heart through an EKG. Remember, a heart attack is not is an occlusion of a coronary artery, but when the myocardial tissue is not being perfused well, it can lead to an irritable heart, one in which the conduction system is no longer functioning properly. And also EKG monitoring will allow us to see, it will reflect ischemia in the heart muscle as well. So we can look for EKG changes that are representative of ischemia. And we are going to be highly focused on assessing the quality and the characteristics of that chest pain. I want you to put a big star here, because I can't tell you how important it is that we address chest pain. Chest pain must be addressed, because the only reason a person with chest pain related to cardiac, the only reason they have it is because the cardiac tissue is not receiving enough oxygen. Okay, when your heart muscle does not receive enough oxygen, it is a priority Okay, it goes right to the top of our list because without a heart muscle, we are not going to continue living. Okay, so cardiac chest pain is very important that we relieve the pain, not because we're concerned about their pain, which is way at the bottom of a list in terms of priority, but because we know what that pain represents. That pain represents ischemia of the heart tissue. We also will want to reassure our patients because they're going to be fearful. When a person has cardiac chest pain, they are afraid they are going to die, and they might. So we have to try to calm them down, to reassure them, especially if it's just angina and not a heart attack. We can, perhaps we can give a little more reassurance. Now, there will be changes to the patient's vital signs when they're having angina, and they also may appear diaphoretic, cool and clammy. Remember, cool, clammy skin? What it means is that their skin is not being perfused. In fact, that the patient is having perfusion issues. Okay. They also can be emotionally distressed, as we already said, that they are scared, they are frightened. And we also will see changes in their vital signs throughout this process. There's a lot of client education needed in our anginal patients, patients who have angina or chest pain. Okay, so again, we look at precipitating factors so that they can identify them in their own life, and they may even be instructed to take sublingual nitro prophylactically ahead of these factors that precipitate their chest pain. We will definitely address lifestyle changes so that we can hopefully improve perfusion to the heart muscle, and they have to be educated about their medications. They're going to be taking cardiac meds, and that's why we are learning all about some of these cardiac meds in this course so that we can educate our patients as well. And we will educate them regarding their diet, again, the low-fat, low-cholesterol diets, and exercise, routine cardiac exercise that even promotes the formation of collateral circulation, and risk factors. What type of risk factors do we educate them about? Well, certainly the modifiable risk factors. So we have to look into their lifestyle and see which factors that we might be able to assist them with. If there's a whole bunch of things that they need to change, it's a good idea to start with maybe just one. Okay, we don't want to overwhelm them, but if we can just choose one to work on first, that would be a great goal for them. And certainly if they're smokers, we want to promote cessation of smoking, and we would address that with our patient. Because again, the nicotine in cigarette smoke does cause vasoconstriction of those coronary arteries, and that would be detrimental to their perfusion to the heart muscle.